Today is Health Inequalities. This is all about utilising clinical audit to effectively address health inequalities. The event will be recorded, so it would be lovely to see your cameras on, but again, as we've said in the last couple of days, if you don't want to have your visuals on the recording, then please turn your camera off now, and Sonia's going to start recording for us. The chat function's live, so we do ask you to remain muted to allow less noise for our speakers in the recording, and please feel free to post any feedback from your organisations or questions that you want us to try to respond to. Delighted to say that shortly we're going to hear from our key speaker, Dr. Aoife Molloy, Senior Clinical Advisor at the National Healthcare Inequalities Improvement Programme at NHS England. That was a bit of a mouthful, so if you don't mind muting if possible, please. Thank you. Aoife's going to talk to us about her work nationally and linking into the clinical audit arena to further drive this really important agenda. It's talking about including equity and access to health and care, particularly when we're measuring and when we're taking action on those clinical audit findings. We are going to hear the winner of our Health Inequalities Audit Hero Award as well, and they'll speak to us about their experiences of effectively utilising clinical audit to address health inequalities in health and care. And then it was just another quick mention here for you to bear in your minds as we go through today's Lunch and Learn and the rest of the week is about the recently published Delivery and Continuous Improvement Review from NHS England by Catherine Pereira, the Programme Director, where the NHS Impact Improving Patient Care Together was introduced. And it's all about this new single shared NHS improvement approach. And we're going to hear more from Vin Dawakar, the Medical Director for Transformation at NHS England, at another event that's being held on Teams tomorrow afternoon between 3 till 4 p.m. and that's booked via Eventbrite. So if you can make it, then please do go and book a place. If not, it will be recorded as well, and we encourage you to go and listen to this afterwards. So if we move on to the next slide then, please, Sonia. Just quickly running through the agenda in a little bit more detail. We'll be setting the scene again in terms of what Clinical Audit Awareness Week means to the clinical audit and wider QI community, and of course with that focus today on health inequalities. Aoife will speak to us as a key speaker, as I've mentioned. She'll announce our Clinical Audit Hero winner for us. They'll present their submission, and then we're going to move on to allow the opportunity to ask questions. Please do, as I say, keep posting your questions in the chat as well. If we don't get a chance to answer them all, we are going to pull together a Q&A document post Lunch and Learn, and we'll try and publish the responses where we can for you. Before we close at 1:30, we're going to share with you an interactive evaluation on screen on Menti, so we'll move you towards that in the last 5 minutes of the Lunch and Learn. But please do, as you're listening and you're interacting throughout today's session, please do think about your key challenges that you're going to take away and take forward in your own organisation. So if we could move to the next slide, please, Sonia. We're just going to quickly recap on NQICAN for anybody that's not aware of NQICAN and its networks or wasn't able to join us earlier on in the week. So NQICAN currently consists of 11 regional networks. We have a common purpose and forward plan of working with teams and clinicians in organisations to make sure that they're delivering those high quality local programmes to make sure that we are improving health and care for our patients and service users. Our regional network chairs have been interacting throughout the week in Clinical Audit Awareness Week. You may well have seen them out and about in their organisations within the regions or quite active on Twitter. So NQICAN holds open meetings now, and the next meeting is on the 29th of June at 10 a.m. on Teams, and it's a free to access link for anybody to join, where we get updates from national organisations such as NHS England, Healthcare Quality Improvement Partnership, NICE, Getting It Right First Time programme, and we give our NQICAN update there as well. Sessions are always recorded, and you can access those links afterwards if you can't actually make the meetings. So if you're not yet a member of your regional network, Sonia's going to pop some links into the chat, so you could email us and we can put you in touch with whoever your local regional network chair is. We also have a network and sharing forum for NQICAN Again, we'll pop the links in the chat for you to request to join if you're not yet a member there. But again, it's about going on and interacting with peers and colleagues and sharing what's worked well, what hasn't worked so well. So we're kind of sharing and reusing rather than reinventing. More recently, we also saw the launch of the National Learning and Knowledge Hub on the NHS Futures platform. That hub's focused around taking action on national clinical audit findings, and it's about bringing the community together to support one another, to celebrate where we have achieved quality improvements for our local communities, and that we are providing examples and case studies and sharing where we've actually managed to make things even better, what might work in one organisation that could be applied to another. It's in its infancy. It's going to evolve as we network and share, building that repository of resource for us all. And as always, we follow the 4 stages of clinical audit. You can see our 4 stages here on the slide, and it's all about us identifying that area to improve, measuring for improvement, implementing actions for improvement, and of course, evaluating that impact, and with that particular emphasis on equity and access and sustaining those improvements. So the topics this week have touched on this every day in the drivers behind our programmes of clinical audit for improvement. HQIP have recently published a quality improvement magazine called Cornerstone. It was launched. It's a new online free publication. It's designed to support quality improvement in health and care, aimed at any of us that are passionate about improving patient outcomes for evidence-based care and services. And you can access this through the HQIP website, and we'll pop that link into the chat for you as well. So this week has been about us taking time out to reflect on what we've achieved since Clinical Audit Awareness Week last year and where we want to be this time next year when hopefully we're running Clinical Audit Awareness Week 24. It's an opportunity to celebrate what we achieve every day in our roles, whether we're in a clinical audit team. I'll just ask everybody to mute if possible, please. It's not just about a week in time, but what we're all pledging to continue to achieve through year, and it's that move to that continuous improvement. We want to learn and share together, much more wider scale, understanding the challenges to effectively getting the most from clinical audit as a quality improvement process. But this week is giving us time to reflect really and set ourselves our objectives for going forward. So if we move on to the next slide, then it's just wanted to share with you what we challenged you with last year, really, about aligning your clinical audit strategy to making sure that you are addressing those health inequalities, that we are including audits that do take measurement on the issues or concerns that are actually being raised, and that we do actually focus those actions for improvement on addressing the health inequalities and looking at equity and access for all patients and all service users. So finally, if we move to my last slide before I hand over to Dr. Aoife Molloy, here is what you told us last year on your Mentimeters that we filled in on the Lunch and Learn. We did share these at the September 22 Open NQICAN meeting, but we're just touching on them again today, just to recap, to set that scene before Aoife starts speaking with us, really. But we asked you, in terms of clinical audit, what does addressing health inequalities mean to you? And these are really, as you worded them on the slide, and it was all about really understanding that data. It was making sure that we know what our local communities need, what their health needs are, but also what their expectations are, and making sure that we are responding and making sure that we're making improvements that really do open up that health and care to all at the point of need when they really need to access it. So I'm going to hand over now to Aoife to take over to speak with us all on healthcare inequality. So it's over to you, Aoife.
Thank you very, very much, Victoria, and thanks very much for having me speak to you all today. Lovely to see so many people online. And so I'm going to just take you through the sort of national strategic priorities for addressing healthcare inequalities across the country. I work in NHS England in the Healthcare Inequalities Improvement Programme, and I also work in the Royal Free as a consultant in acute medicine and infectious diseases. So I think I spend a lot of my time trying to bring the national aspirations into the real life of clinical medicine. And I'm a real big fan of QI and audit for actually being able to do that. So my slides I'm just going to take you through now will really just focus in on the tools that are available, using data to inspire change, and how to measure the success, and just to kind of really familiarize yourselves with the support structures that we're having in place, but also developing rapidly as well. I think there's, since COVID, there's been an enormous kind of call to action. There's been a really important highlighting of the devastating effect of healthcare inequalities. But I also know that a lot of us on this call and working in the NHS and in the supporting organisations know that healthcare inequalities have been pervasive throughout healthcare, not just in the last decades, not just since the founding of the NHS 75 years ago, but really going back centuries. I think it was really startling for me recently. I started getting into a rabbit hole about the data and realized that the mortality gap between most and least deprived in this country in 2023 is quite similar to the mortality gap that existed in the 1800s. And this is something that really just makes me feel like, enough is enough, and it's really time to make a difference. So our vision as the Healthcare Inequalities Improvement Team is about exceptional quality healthcare for all. And the emphasis is on all, whether that's somebody with inclusion health needs, somebody in contact with Her Majesty or His Majesty's prison system, whether it's a deprived community or a minority ethnic community. So what we're really doing is a targeted approach to healthcare inequalities improvement. And we're trying to improve access because we know that people have to get to the NHS, or the NHS has to get to them to make a difference. But it's also a focus on experience, and we know that poor experience of healthcare in the NHS can result in not only the patients not coming back again, but also their friends and families having a very poor impression, and it kind of exponentially drives the stigma, racism, discrimination, and all these microaggressions that actually damage health outcomes. And we know from a lot of research in America that these microaggressions and discrimination events actually have an effect on outcomes, increasing blood pressure over long term, and decreasing outcomes, including shortening lives. So it's just a reminder about kindness and trauma-informed approach in healthcare. So improving access and improving experience, we hope, will actually lead to optimal outcomes and really narrowing the gap. So I'll take you through my slides now. Thanks, and to the next slide. I just wanted to remind you all, and I know you all know this, but health inequalities are systematic, and we sort of see that every day, and some of us experience that every day. But they're also avoidable and they're unfair. And I think this is the part of the definition for me that means the most. It's that we actually can do something. It's not just variation or just the way things are. They're avoidable and they're unfair. So we can do something about it, and actually we must do something about it. Next slide, thanks. And that's our vision as I just went through. Thanks. Next slide, please. So as I mentioned, we have this huge mortality gap between most and least deprived communities, and we're talking about 20 years of life. So people in more affluent communities are living a full 20 years, full 2 decades longer than people in more deprived communities. But the gap in healthy life is even wider. So not only is life shortened by inequalities, but actually it's the quality of life is much worse. And the knock-on effect of this on the economy, on the healthcare system, it is huge. In terms of the demand for care, or the emergency department attendants trying to do elective recovery fairly, recurrent hospital admissions. So often I hear people sort of say, well, look, what can the NHS do? We're struggling with all these sort of socioeconomic problems. We're trying our best to influence and lobby, but what can the NHS do about social isolation or housing problems? And so it's really about sort of thinking what's within our influence. And on the next slide, I just wanted to really reinforce the idea that this is not just about deprivation. There are huge ethnic inequalities in the UK, real structural racism. So we know that a quarter of all deaths from cardiovascular disease are in Black and minority ethnic groups, and cardiovascular disease deaths are actually considered preventable. So these are avoidable deaths, and a quarter of all the people that die from cardiovascular disease are from Black and minority ethnic communities. So we are finding that there are massive problems with access and experience, as I highlighted earlier. For example, with only 5% of blood donors are actually from Black and minority ethnic communities. So there's a real problem with access to all aspects of healthcare. And then I really want to emphasise the outcomes in Black mums and babies. I mean, it's just really unforgivable that in 2023, Black women are 4 times more likely to actually die in pregnancy than white women, and so these are the kind of markers in the sand that we're really just putting down and saying, like, we need to really improve our way out of this. We need to use all the tools, all the sort of quality improvement methodologies, all the audits. We need to use all the data to really sort of inspire improvement. And on my next slide, I'm just emphasising that it's a problem across the whole healthcare system, from primary care to secondary care to tertiary care. And we've known for a long, long time about this concept of the inverse care law, where the people who need the most care get the least. And this is actually still playing out nowadays, even though this was before the turn of the 2000s that we understood this concept. But it's the reason I'm kind of saying it's avoidable and we can actually do something is in the next slide. You'll see that the importance of healthcare interventions are really significant. So up to 60 to 80% of health is actually attributable to the wider determinants of health, and these are the kind of social issues. And you'll know that the index of multiple deprivation really looks at housing, education, employment stability, and only one of the domains is health. But actually, the impact of the health outcomes, as you'll see in the next slide, is, according to the King's Fund, could be up to nearly half of outcomes can be attributable to outcomes to NHS interventions. So yes, you can see here that between 15%, which is still not bad, and 43% of health outcomes are actually directly under the influence of the NHS in terms of inequalities. And, sometimes I think if this was a tablet or a vaccine, we would probably all be queuing up to try and address it. I see somebody has their hand up.
We can come to questions a bit later on if that's okay, Aoife. We'll let you keep speaking.
Yes, perfect. Yeah, perfect. Thanks. So if you just move to the next slide, what we know and what we understand from reams and reams of data and experience data, qualitative and quantitative, that actually healthcare inequalities is a major challenge and that we're facing in the NHS. But it can often feel overwhelming and intangible, not my responsibility, all of that. So what we're doing with Core 20+5 is really trying to hone in on the most important parts of healthcare inequalities. So if we're moving on to the next slide, you'll all be familiar, hopefully at this stage, with the concept of Core 20+5. So we have it in children and young people. And we're really talking about not doing a sort of one size fits all population approach. We're talking about really targeting our energies towards the 20% most deprived, as defined at the national level according to the index of multiple deprivation, and then the plus groups, which are defined locally by ICSs. And the plus groups really include anybody who's experiencing poor health outcomes due to life circumstances and health inequalities. So this includes people with learning disabilities, people with severe mental illness, people in contact with the justice system, people with inclusion health needs, and migrants, and people experiencing homelessness. And then the 5 key clinical areas are chosen because they're the areas where there's the biggest gap. So you'll see the chronic respiratory disease, early cancer diagnosis, and hypertension case finding In the Lancet Global Burden of Disease study, these are the 3 clinical areas where the gap is over 20 years in life expectancy between most and least deprived. And then we've put maternity care in there because of the findings of the Embrace study, Embrace audit that I mentioned earlier. And we've also put in severe mental illness because we're really trying to improve the actual physical health of people living with severe mental illness, because they are in contact with the NHS, and there are perhaps lots of missed opportunities to really optimise their secondary prevention. And we've also, I'm delighted to say on the next slide, got the Children and Young People Core 20+5. And this is just to really highlight, how important health inequalities are. They have an impact even before birth. And we've really worked with the Children and Young People team and the Royal College of Paediatrics and Child Health, and lots of system leaders. And I will emphasise in children health, it's much more of a system-led piece of work, because it is related to education, public health, prevention, promotion of health, diet, housing, poverty. So I sort of feel like with the children and young people work, it's much more woven in with the ICS as an integrated system, perhaps maybe where hopefully the adult health will eventually go. And we've got the 5 key clinical areas there, which are very different to the adults. And I just want to highlight one thing: it's the oral health. So in this country today, we're still taking out, children's teeth that have decayed, and it's the most common reason for a child having to have a general anaesthetic, which carries the risk in itself to have to be put to sleep, to have their teeth removed because they have simply decayed in their mouth. And this is, as I mentioned before, the same approach that was used in the 1800s, just to pull out the teeth because they had all decayed, and they affect the growth of the adult teeth and the mouth and the speech and everything. So that's sort of why that's there. But in epilepsy, we're seeing enormous differences in outcomes between most and least deprived, and between the white and black and minority ethnic groups. And in mental health, I think this has really been exacerbated by COVID. So we know that all the child and adolescent mental health services are completely overwhelmed, with 3- or 4-fold increase in referrals since COVID. And in diabetes and asthma, I mean, our rates of deaths from asthma in the children has been brought to the attention of the National Coroner, because it's outstanding in a very bad way, when we're comparing to other countries similar to us around the world. And so if we move on to the next slide, I think you'll see we all know there is a case for change, and what we've been trying to do over the last 2 years since the setup of the Healthcare Inequalities Improvement Team is really, set up that national policy context. So it's in the planning guidance, it's legally there, it's in the mandate to the NHS, it's in the Constitution, it's in the Health and Care Act, it's written through the whole long-term plan, and all the COVID-19 elective recovery plans and high-intensity user plans are all really having a strong focus on healthcare inequalities. So this is to sort of set up the legal and policy context for addressing healthcare inequalities. And if you see on the next slide, we've been working with NICE, and so we have a sort of healthcare inequalities improvement planning matrix, and I would really advise you to use this as a tool for your healthcare inequalities improvement projects. And this is really a sort of a lens with 7 domains, just to sort of make sure that each intervention is very holistic and addressing healthcare inequalities for improvement, and not inadvertently leaving out a section or maybe making outcomes worse. So it's definitely worth sort of looking at that as a very holistic lens for addressing healthcare inequalities. And I'm on the next slide. I'm really delighted to say, and I encourage you to really explore this fantastic resource if you haven't already. But NICE have literally gone through every single recommendation in their whole body of guidelines and health technology appraisals, and every case study and shared learning database, and they have mapped everything to every sort of way of looking at healthcare inequalities, whether that's population health management, whether it's Core 20+5, whether it's through the OHID or DHSC. And so what we have here is literally like the Wikipedia of healthcare inequalities, and what to do and how to do it. So I would really encourage you to have a look at that. And then on the next slide, you can see that we've been sort of developing support offers and structures from the national team. So we've got our Core 20 Plus ambassadors. Maybe you've already identified an ambassador in your local area, but we have over 130 ambassadors across the whole country. And these are people like yourselves that are just steaming ahead, tackling healthcare inequalities. And what we're doing is trying to connect everybody together. So there's an expert peer learning group, but also give everybody a platform. So they're linked in with the national team, they're linked in with our network, and there's shared learning and also inspiration kind of spreading around the country as fast as we can. The Core 20 Plus connectors, you can see on the top left, are actually the kind of community components of the ambassadors. So we are funding community champions to really advocate for tackling healthcare inequalities and bring the voice of the people into the NHS and bring the NHS out to the people. Very similar to what happened during COVID, you know, we saw these amazing improvements in health in the COVID vaccination uptake when community champions and faith leaders got involved. We've also got our Core 20 Plus accelerators, and this is a piece of work we're doing with the IHI. And so we've got 7 sites, 1 ICS per region, and they're literally doing a sort of fast-paced implementation of Core 20 Plus 5 and reporting back all the problems that they come across and what works and what doesn't work. And then we're building that all together with the IHI into sort of a national piece of learning, and hope to spread that around the country again. And it's just really amazing to see the breadth of work, you know, from Cornwall working with the Gypsy Roma travelling community to Lancashire working with cancer screening in deprived communities and Black and minority ethnic communities, and that there's really a lot of learning about what works in the real world, which I think is really helpful. And the whole model of that is QI, so it's all QI methodology being tried and tested with healthcare inequalities. So that's the kind of national structures of support and policy to kind of cushion all the approaches to healthcare inequalities at a system level. And I think, you know, you'll all be fans of using data to inspire improvement. And so you'll see from my next slide that we have our healthcare inequalities improvement dashboard. So at a national level, we've got a sort of a mandate that all performance data in the NHS must be looked at with healthcare inequalities lenses. And this comes from COVID. So COVID vaccination campaign was sort of the first time vaccination data was broken down into ethnicity, deprivation, gender, and age. And I'm still boggled as to why we weren't doing that in flu before this happened, and why it's quite slow to get it going on everything else. But I'd encourage you to log on to the Health Inequalities Improvement Dashboard to have a look at the performance outcomes. So we're talking about 18-week wait, or the A&E weights and everything. It's all broken down in several dimensions to capture that intersectionality in healthcare inequalities. On the next slide, it's just we'll share these slides with you. So I've put in all the links, so you can use this as a sort of a resource pack. But we've done some early work with prescribing and prescriptions with the Business Service Authority, and so we've looked at every single prescription that was written in the community in 1 year across the whole country, and we've just found horrible themes coming out in terms of uptake of exemptions to prescribing charges, but also in the pattern of prescribing. So we're finding deprived communities are escalating through the first line, second line, third line very, very quickly. We don't understand why that is, but also the people from deprived communities who are receiving some of the nice non-recommended medicines for sort of severe mental illness and for COPD. And we're finding a lot of emergency drug use and that in the Core 20 population. So there's some very worrying trends that we've identified, and we're working with the BSA, the Business Service Authority, to sort of delve into the further questions that are coming up out of this work. And then on the next slide, it's just to remind you that there's such a sort of societal call to action at the moment, and the Chief Medical Officer's report on air pollution really was staggering in terms of how much it emphasised the overlay between healthcare inequalities and pollution, and the adverse outcomes. So it's seeming like there's just layer upon layer of challenges piling up on people experiencing healthcare inequalities. So we've done some work with NCAPOP on the next slide about how the national clinical audits really highlight healthcare inequalities. Some were absolutely excellent, and then others were, less formal about it. So what NCAPOP have done, and this was led by the clinical audit leads, is that they've really committed that every single audit will, number one, collect data that's relevant to healthcare inequalities. Number two, analyse the data in a way that draws out the healthcare inequalities. And number three, really sort of commit to considering healthcare inequalities across the recommendations, whether that's having bespoke recommendations or weaving it through all the recommendations. So I think this is a fantastic move to standardise the approach to healthcare inequalities. And I know in the next slide that you've spoken already with Hess Wayne from NHS England about this NCPOD review, and I just wanted to put it in here so that you have the link. But this was a really emotive report where they looked at all their data of very adverse outcomes across the whole of the NHS and found that actually healthcare inequalities were woven through all the cases that they looked at. So again, this is just to emphasise that there's sort of no escape, and it's a very sort of complex overlay of things. You can see in our next slide as well that we're looking at patient safety outcomes and healthcare inequalities. And as you all probably knew, the impact of patient safety adverse outcomes is just much more concentrated on people already experiencing healthcare inequalities. So there's a new clarity around how serious this problem is, and there's also much more of a move to actually turn to action rather than despair. So the policy context is set up, the tools are there from NICE, and then I'd like to draw your attention on the next slide to the e-learning modules that we have developed with HEE. So we're developing more and more and more all the time, but these few first modules are absolutely excellent, and I would encourage you all to have a look at them. So we've covered all the 5 areas for adults and sickle cell disease as well. It takes about 30 minutes, and it's open to everybody to access and log in on the e-learning for health website. And finally, our futures page on the next slide is where we have all our what's new, our case studies, our opportunities to link up, to showcase material, and recordings of all our network meetings. And we have a new toolkit as well, so sort of how to put the NICE guidelines into practice in reality, how to actually navigate the data sets, how to make a slide pack and kind of use data to inspire improvement, how to measure for success and evaluate. So really going back to those 4 areas of the quality improvement and audit projects that Victoria highlighted earlier. So yeah, I'll stop talking there, and we can move to questions. Thank you very much, and we'll share the slides with the links.
We're going to get you to move on to announce the. Is that all right, Aoife? And then we'll move to questions a bit later on. Lovely,
perfect,
thank you.
Perfect, yeah. So yes, I'm absolutely delighted to announce the highly commended and the winners of the National Clinical Audit Hero Award. So our highly commended Clinical Audit Hero is Mikaela Wardle, who's a GP trainee, and she has done an amazing project in partnership with the homeless patient team and the alcohol care team, all about inclusion health in the emergency department. So very much like having a very holistic, caring approach to patients who are homeless or socially excluded. And we have a new national pathway actually from NHS England on having a very holistic approach, but also making sure all the legal duties are recognised and the duty to refer is there. She captured all of that in her audit, and she's been awarded highly commended. It's excellent work. And so on to the winners of the Clinical Audit Hero Health Inequalities Award. So we have the team from Sandwell and West Birmingham hospitals, and they've come first place. And it was a team of people including Menik Upatisa, Michelle Fleeman, Isabel Cowling, and Indu Mahabir. I just want to say a very warm congratulations, well done. And we're actually going to hear from this team to tell us all about what they did.
Lovely, thank you so much. So thank you for that introduction. So my name is Isabel Cowling and I'm a paediatric registrar working in Birmingham, and I'm joined by one of my consultant colleagues, Menik Apatissa, today. We wanted to start by saying a huge thank you for this award. It was a huge privilege to have been recommended for the award, let alone to have won. So thank you very much. And a particular thanks to Rebecca from our trust who nominated us. Before I present the findings of our audit, just as a disclaimer, I'm aware that this is a highly emotive topic, and some of the media images and patient stories which I will be sharing today may be slightly overwhelming for some listeners. However, we feel that this really does illustrate the huge importance of addressing and combating healthcare inequalities in this patient group. So just as a bit of a background, many of you may remember this shocking image of a young Syrian refugee called Alan Kurdi, who tragically drowned whilst trying to cross the Mediterranean Sea along with his mother and brother. This image on the left was taken in September 2015, but has much changed in the 8 years since then? Well, we know that the migrant crisis looms larger than ever, with record numbers of people being displaced globally due to war and conflict. And only as recent as last week did we hear of yet another tragedy with a shipwrecked migrant boat off the coast of Greece containing a number of children and young people. Next slide, please. A recent analysis by the Home Office has illustrated that in 2022, over 45,000 men, women and children crossed the Channel to reach the UK, and over 8,000 of these were children. This has led to increasing numbers of unaccompanied asylum-seeking children receiving healthcare as looked after children through community paediatric services. Next slide, please. Unaccompanied asylum-seeking children have complex and unique physical and mental health needs due to past experiences of trauma and violence, poor access to healthcare in their home countries, and their inherent vulnerabilities as children. There's also increasing evidence to suggest high levels of tuberculosis infections and bloodborne virus infections in this patient group. Next slide, please. So the aims of our project were to assess the demographics and health needs of unaccompanied asylum-seeking children attending looked after children's clinic in our trust. And we wanted to identify gaps in practice and look for opportunities to improve the management for these children and young people. So to do this, we analysed the initial health assessments, which are statutory health assessments conducted for all looked after children. And we also looked at the blood and investigation results for unaccompanied asylum-seeking children attending clinic between September 2020 and November 2022. And we audited the data against national guidance recommended by UASC Health. UASC Health is they are an organisation which were established in 2019 in order to help healthcare professionals assess the health needs of asylum seekers. So our results found that during the study period, we identified 43 initial health assessments. 79% were completed within 28 days, and 28 days is the nationally recommended time frame for which these assessments should be conducted. The mean age at the time of assessment was 16 years, although this ranged from 13 to 17 years. The vast majority of the young people were males and a smaller proportion were females. Consent was gained for all of the assessments, and the majority were conducted via an interpreter as English was not the first language. In terms of the countries of origin, the most common countries of origin were Afghanistan, Iran and Iraq, and this is reflective of the overall most common countries of origins for asylum seekers entering the UK. We also had children who arrived from Chad, Vietnam, Albania, Syria and Eritrea. We also looked at the journey details and found that reasons for fleeing from their country of origin included war, political opinion and religious persecution, although for the vast majority of young people, they did not wish to share the reason that they had left their home country. In terms of method of transport, again, this varied greatly, and for a proportion of young people, they did not wish to disclose how they had entered the UK owing to fear of persecution. The average duration of travel was 11 months, but again, this varied greatly. We also looked at whether the young people had experienced physical or sexual assault during their journey. And shockingly, we found that 2 out of the 3 females had experienced sexual assault, and 10% of the males had experienced physical assault, including being beaten and robbed by police or other traffickers during their journey. Here are a couple of the testimonies which are lifted directly from the reports and just highlight some of the awful circumstances that these young people face whilst trying to arrive in the UK. Health promotion also forms a really important part of the healthcare assessment, as we recognise that large numbers of asylum-seeking children will have incomplete or unknown vaccination status. And in fact, this was the case for our cohort, and all of the young children, we didn't know the vaccination status, and so they were therefore referred for catch-up immunisations. Lifestyle issues, including diet, exercise, smoking, alcohol and drug use, were discussed with all the young people. And whilst all denied alcohol and drug use, 14% were found to be smokers, and appropriate smoking cessation advice was discussed. So in terms of screening for asymptomatic infections, the guidance is that tuberculosis screening should be performed for all unaccompanied asylum-seeking children arriving from countries with a TB incidence greater than 40 per 100,000 of the population. So 88% of our cohort were referred for TB screening, and of those tested, 1 was found to have active pulmonary tuberculosis. However, as you can see, for the great majority, actually these tests were not performed. Similarly, for bloodborne virus screening, this is recommended for all unaccompanied asylum-seeking children who arrive in the UK due to the high risk of infection either from their country of origin or because of experiences they may have had en route. All of our young people were referred for bloodborne virus screening, but again, not all of them were tested. And of those who were tested, 2 were found to have a previous hepatitis B infection. Currently, sexually transmitted infection screening is not recommended routinely, but only for those who are deemed to be high risk following assessment. And 2 of our young people were referred for sexual health assessments following a disclosure of sexual abuse. Considering the wider determinants of health, including the young person's social network, their access to education and their contact with their family is also of huge importance. We found that 58% were enrolled in education and 7% were awaiting a college placement. 40% were referred to the Vulnerable Children's Team school nurse, either because they were attending a college placement which wasn't in the local area or they didn't have a college placement at the moment. International family contact tracing is a service offered by certain charities and was accepted by 67% of our cohort. Others were already in contact with their family or denied wanting to be in contact or put in contact due to safety concerns. And then 2 young people expressed concerns regarding their current placement. 1 young person felt that their room was very small and uncomfortable and reported missing their family. And a second young person was requesting to move out into shared accommodation. However, it was noted for this young person that they'd been negatively influenced by another young person within their friendship group who was often keeping them out late past their curfew. And there were some other safeguarding concerns. And this just really highlights the vulnerability of these children and the importance of recognising safeguarding concerns and liaising directly with the social care team should these arise. Listening to the voice of the young person is of paramount importance, and all of our young people were asked about their experiences prior to entering the UK. 67% were asked about their future plans, and some of the examples you can see are written here. This just highlights the huge potential and aspirations of these young people, despite the majority having received no formal education in their home countries and in spite of the huge barriers that they face in terms of language, culture and stigma upon entering the UK. So to conclude, Unaccompanied asylum-seeking children have unique health challenges and face unique barriers. From our study, we found that the majority of the statutory healthcare assessments were performed within the nationally recommended timeframe. A really high proportion of the females were sexually assaulted during their journey to the UK. And despite the recommended guidance, bloodborne virus screening and TB screening was not completed in the majority of cases. However, despite a lack of formal education, many of these young people have high aspirations and future potential. So our recommendations going forward are to ensure that journey details are explored in a sensitive manner during the initial healthcare assessment, specifically asking about a history of assault, sexual exploitation, and assessing the trafficking risk. We are also looking to modify the screening pathway for asymptomatic infections because we recognise that this was not performed in the majority of cases. For most cases, we would usually ask these blood tests to be performed in primary care, but as we've recognised that this is often where the screening is missed, we are now changing the pathway so that the blood tests can be performed immediately after the initial health assessment if they are indicated. And finally, we are also in the process of creating an information pack tailored specifically for unaccompanied asylum-seeking children to include health promotion and other mental health care resources, which is specific to our local area. So these are our references. Thank you very much for listening. And if anyone does have any questions or comments, we would be grateful to hear them now. Thank you.
That's fantastic. Thank you so much, Isabel, and your team. I'm going to head over to take raised hands first. I think, Davina, you've got your hand up. You just need to unmute yourself. Okay, we'll move on then to see if anybody else has got any more questions, either for Isabel and her team or for Aoife. Stunned you into silence with information.
Victoria, it's Brad. I've put something in the chat box because I'm not sure my camera's working, but is it okay to offer a comment and a question?
Absolutely,
so
yeah.
The comment I'd offer is, you know, well done, really, and I mean that most sincerely, but well done for the people that we're serving as well, really. You mentioned some of their terrible experiences. I'm privileged, literally 100 yards from me is a refugee and asylum seeker charity, which I visit pretty much every fortnight if I can, really. And just to hear those harrowing experiences reminds us about exactly the narrative inequalities, but the actions of inequalities. So I was part of the panel, so I suppose I declare an interest in that sense. And I obviously Caroline and Kenny were there as well, so I'm not sure what I can say and what I can't say. So let's just say what I can say, really, is it was so outstanding when we read it and whatever. It was so obvious and whatever. So, you know, good on you. But what I'd also like to say, really, before I forget anyway, is also to thank all the other people that submitted applications as well, because sometimes even if we don't mention them in terms of here, really, we must acknowledge them in terms of their submission. So great work or whatever. Question. So in terms of all the resource implications, and we haven't got this and we haven't got that and whatever, sometimes I hear, but also I hear we have got this. What would you like to do more of?
Who are you aiming that to, Bren? Isabel's team or to Aoife?
Sorry, Isabel. Yeah, sorry, I was done on the
yeah.
So Isabel and the team, really. So this is what we've got. It's great, and let's take a moment. Also, sometimes we don't always do in the NHS and beyond to actually just say, you know, good on us, really, and pat ourselves on the back, as opposed to someone said, you're not doing this, you're not doing that, not doing the other. So a moment of self-congratulations, which is good. But what would you like to do more of, or whatever, really, if you have that opportunity to go forward, or you are going to do more of? Isabel and the team.
Thank you. So I think the main thing would be, for me, I mean, I'd like to see that all of the young people who should have the asymptomatic infection screening, that's completed. So to see if they have tuberculosis or bloodborne viruses. I think that figure should be 100% in my view, particularly for people who don't have, a parent or guardian with them to necessarily advocate for them. And then I guess in terms of a wider question, I think I'd like to see more targeted kind of mental health services or other support services for this group of people, because although we have an amazing CAM service, for example, actually how much of that is specific for these young people who actually have very different health needs. So that's what I would say in answer to your question, and thank you for your comments.
Thank you.
Lovely, thanks Brenna, thanks Isabel. Monique, you've got your hand up. Monique, I don't know if you could turn your volume up at all. It's sounding very quiet. I'm assuming it is for the others as well.
Can you hear me now?
That's a little bit better, yes, thank you.
Okay, sorry about it, I'm in the clinic room. So yeah, going forward, I mean, as you saw, Isabel and our team, like we really captured what the loopholes were in with these children's care. And adding on to what Isabel said, we are in discussion with the phlebotomy services and the TB screening services. So at the moment, we are in discussions to see how effectively we can give this service. And also what we are planning to do is, as Isabel said, some of these children, when they come for their initial health assessments, what we saw was they were not aware like why they were here, and like so much anxiety and stress. So we are thinking of in an ideal world, yes, if we could, we were discussing about making a app if possible, so that like most of the children are given mobile phones by the social services team. So they do have access to apps and like online services. So just to give them kind of like what's going to happen in the IHA, and then what are the resources for them to access if they think like they need to kind of get more details. So that would be kind of like our dream project, isn't it, Isabel? We have discussed, yeah. So just wanted to add that. Thank you so much.
That's really, really valuable to hear. Thank you. Okay, we're going to, is it Indu next? You've got your hand up.
Yes, hopefully you can hear me as well. I'm Indu Mahabir, so I'm one of the doctors that does assessments for our young people in clinic. And I think what we realized through the audit is that this was a really valuable health opportunity and health promotion opportunity, and we needed to utilize it more. When it came to the screening, it was very clear what we needed to do, but it was just giving that health empowerment to this group of young people that are really vulnerable. And as we said, we're having ongoing discussions about what else do we offer them to understand, because the conversations are very basic, as in we'd say, okay, we will ask your GP to do this, but actually these young people don't know what a GP is. So we have to go back to the basics to explain what the health service looks like in the UK and who you'd be accessing and who you'd be speaking to should you have difficulties. Also, in terms of the nature of the cohort of the children, they move around as well or get placed in different areas. So we might miss that health opportunity. So it's just for us to think about going forward, as Minik and Isabel said, we need to think about what kind of information do we give them at that point in time to ensure that we've done our bit of the puzzle here, really. So yeah, just wanted to make that comment, and thank you very much.
Oh no, that's brilliant, thank you. And Carl, you've got your hand up.
No, great, thank you. Hopefully you can see me all right. Well done to both speakers, fantastic pieces of work, both in the terms of the national agenda on this and on the refugee work. That was very humbling, especially when you're a parent yourself, sort of thing. But Yes, I mean, in terms of practical tips going forward, we're obviously all on different journeys here. In Leicester, I've shared in the post where we're trying to take this forward in our local trust, and I just wondered if either of the speakers had got any tips for us to how we can take this forward in terms of a sort of meaningful way, in terms of a doable way, I think I mean.
Brilliant, thanks, Carl. Is this one for you, Aoife, maybe? Top tips.
Yes. Yeah, top tips, no problem. Well, I think first of all, I think joining the sort of Futures website is really helpful, and I think I would really encourage you to join into the monthly network call. So that's a sort of a clinical and professional meeting the third Tuesday of every month in the morning. And if you can't make it, that's actually recorded. But that's a really good place of sharing best practice and inspiring, quality improvement, and then kind of sharing between people really and organizations. And then we also have the forum, which is also a monthly meeting, but this is more sort of for the upside and finance managers and that is all about all the contractual stuff and everything. So I think those two meetings are really complementary. And if you go onto the Futures website, that you can join on there. I think we now we have regional leads for healthcare inequalities and ICS level leads for healthcare inequalities. So if you want to actually find out who your leads are, if you're not already in touch with them, you can contact us on the Health Inequalities team, and I've put the email address in the website. But I think that's a really good way of kind of understanding who the local network for healthcare inequalities is, because often what we're finding is people are working very hard on their own sort of individual projects, but there's so much strength in bringing people together. So they would be my sort of top tips, like find your allies, use the data that's already there. There's so much to kind of really inspire people into action. And then our toolkit online, I think on the Futures website, I hope will be really helpful.
Thank you.
That's brilliant. Thank you. Thanks for raising that, Carl, and thanks, Aoife. So that sounds, we've had a wealth of information, absolutely accessible for us all now. And obviously you've put all the links in your slides, Aoife, as well, which is brilliant. So we will upload the recording and slide packs to the HQIC website and the NQICAN websites as well. So I'm just going to briefly take probably over screen sharing, if that's okay, Sonia, as I go to the Futures website. Here we go, and present for you. So can you all see a Menti that's come up with the last few minutes of the lunch and learn? There's a QR code there for you to either scan, or you can alternatively put menti.com and this code in. Before I move on the slide though, I'll just give you all a chance to scan that. I'll just see the numbers come up first before I move you on to the first question. So we've got a few questions for you, and then obviously we'd like a little bit more feedback for us as we go forward. So I'm going to move on to the next slide then. So you should all, now you're logged in, have a few questions here for you to pop in on a scale of 1 to 5 of how you found the key speaker presentation. Was it interesting, engaging, the right level of information? Have you managed to take some of those top tips away and key information back to your own organisation or your role or community setting that you can take forward in terms of addressing health inequalities? Again, as we heard from our winning entries, how was their information that they shared for you? And also, again, would you recommend these lunch and learn sessions to others? So I'll just give you a minute to be popping your responses in there. These are all looking very positive, which is fantastic. We're really grateful for our key speakers and winners each day that are sharing this wealth of information with us. So I know we're all committed to try to take forward this important agenda. So I'm going to move you to the next question. So what is your top takeaway from today's session? What have you learned from this session that you're going to use in your work? So you should be able to type in here, and we should start to see some of your responses coming up on the screen. We will also share the outputs of the Menti as well, so that you can obviously see everybody else's posts and take some of that information back into your daily lives as well. I'm not seeing anybody. Oh, here we go. Lovely. They're popping in now. Fantastic. Yeah, being mindful of health inequalities when developing local audits, absolutely. Promoting projects that improve those health inequalities, be mindful of these. Brilliant. Yeah, I'll scroll up for you all so you can see. Yep, involving our harder to reach communities or our seldom heard. We need to make those steps to reach those individuals and groups. Yeah, there is a lot of work going on out there. It's just about us taking some of that sharing and some of that learning and applying it to our local programmes in our organisations as well. So it's definitely worth you finding out who your local ambassadors are, who your leads are in your ICSs, as Aoife said, and really understand the health inequalities for your own areas, but also then the work that's already going on, so we're not duplicating, we're complementing, and find those gaps where we can channel our resources to further strengthen this agenda. This is really good, and it's really valuable. Keep posting. You're obviously on the Menti and it will remain open. I'm just going to move to final question as well, in terms of any additional feedback about today's session that obviously we can take on board for running future sessions for you. So I'll let you post on there as well. So conscious that we're now a minute past 1:30, so I shall stop sharing my screen there and come back to you all so that I can see you. And it's really a big thank you again to yourself, Aoife, and obviously to the Highly Commended and obviously our winners as well. All winning entries throughout the week are being written up as case studies as well and will be available on the HQIC website. So alongside the slides, you'll get those case studies to access as well. Please do join us for tomorrow if you can. We've got Deborah Cundy from the Making Data Count team coming to influence us again on how to effectively make change in response to clinical audit findings. So they'll take us on our next steps of that journey. So please do join us at 12:30. And again, if you've got the opportunity to join us for the NHS England event between 3 and 4, where we'll hear from Vinda Awakar and Michael Sykes about taking action on National Clinical Audit. So have a lovely afternoon. Keep sharing all your plans for Clinical Audit Awareness Week and what you're achieving. And for those that can join us, we shall see you again tomorrow. So thank you very much.